have, I believe, an exciting meeting with great speakers. So it'll be a bit complex because we have speakers online, we have speakers in the room, we have some who have slides, some who don't have slides, and one who will speak French, and I will manage some translation. But the purpose of this is really to bring us to speed with the concrete reality of one disease in the field and concrete actions of in considering preparedness and response. What can we do? What have we not done so well, maybe? What can we do better? We will have about 30 minutes at the end of the meeting for Q&A discussion with you. And we will have closing remarks on behalf of Dr. Almandari, who is the DG of EMRO. So with no further ado, I would like to introduce you to Dr. Kawaya, who comes directly from the Democratic Republic of Congo, and who is going to speak about the reality of Mpox in the DRC. Mpox is not over in Africa. It's not a fake anymore, but it's still happening in Africa. And we will see where the patients are, how they present, what are the specificities. Following this, we will have Beatriz Grinsztejn from FIOCRUZ, who will reflect on the other aspects of this disease in Brazil. So, Dr. Kawaya, please. Before we start, I'm sorry, we have a video from, as an introduction from our president of PANTHER that I would like us to watch now, please.
Good afternoon, dear colleagues and friends, and welcome to this important side event at the 76th World Health Assembly. My name is Samba, and I'm the president of the entity known as PANTHER. I am sorry not to be with you in person, but circumstances prevent me from being in Geneva. Over the next 2 hours, we will be discussing why I believe this collaboration is so critical to Africa's future. This event is a follow-up to a symposium we held in Kigali a few months ago, and will build together on the much-needed momentum. We cannot forget what we have been through over the last few years, and therefore risk the health of our countries and communities further. We all know that pandemic preparedness has become a more of a priority due to COVID-19, and that there are high-level discussion going on. But for the global vision to be a reality, it has to be linked to the ground. There is no global without local. Over this session, we will hear from my colleagues on some case studies which will show locally developed and built models of preparedness and how we need partners to take on funding to support us to develop these efforts. We really hope that this session will be action-oriented and that you will all leave here with ideas to take forward, ideas which can be taken away and developed into something meaningful for your local context. Thank you again for attending this important event. COVID-19 caught us unaware and caused untold damage to global progress towards our goal of equitable health for all. In real terms, the pandemic led to worsened health equity, which continues to compromise communities' development and progress. We cannot let this happen again, and therefore we must use this peacetime to prepare for any further war against the next pathogen, against the next health threats. Thank you again and wish you a productive event.
Thank you, President, and I hope you're online, and I hope you can connect, you could connect yourself. So, cher Dr Kawaya, est-ce que c'est possible d'avoir la présentation? Je donnerai un peu de traduction si besoin, mais je pense que la présentation est très explicite en elle-même.
Bonjour à tous. Bonjour à tous. Oui, je suis Dr Kawaya, comme on me l'a présenté. Je suis chercheur à l'université de Kinshasa, en République démocratique du Congo. Nous travaillons sur les Mpox et on voulait vous partager la réalité que notre population vit chaque jour et nous-mêmes comme chercheurs et médecins dans ces coins du monde. Alors déjà, pour arriver dans nos sites, il faut du temps parce que c'est en moyenne 500 km par vol d'oiseau et la route ou les routes pour y accéder est très difficile. Donc par exemple, pour nous, nous avons des sites en République démocratique du Congo, ce qui fait que quand il faut y aller, ça prend en moyenne beaucoup de temps. Et nous rappelons que lorsque nous allons, c'est pour rencontrer des malades dont la majorité est âgée de moins de 15 ans. Et aujourd'hui, le taux de létalité pour les Mpox en République démocratique du Congo est plus de 10%. Et voilà donc l'accès, comment il est difficile. Des fois, nous devons marcher sur les rails pour accéder dans ces sites, ce qui fait que vu que l'état des routes ne permet pas de prendre la route ordinaire, nous sommes appelés à marcher sur les rails pour accéder à nos sites. Alors, les investigations sont faites dans nos sites que j'ai cités. Il y en a 3, donc déjà qui seront, je crois, opérationnels. Et les kilométrages, c'est à peu près 900 km par moyenne par vol d'oiseau. Et il faut après prendre des motos, prendre de pirogues motorisées pour accéder.
Peut-être je vais juste... Est-ce que je peux avoir un... Thank you very much. So maybe just to say that, as you have seen, it's very difficult to reach those patients. From Kinshasa, it's 900 kilometers, but it's also very far. They need to take motos or they need to take boats. So to access those patients is really already a challenge.
Alors, pour mener ces recherches, il faudrait d'abord avoir le consentement des patients qu'on enrôle. Voilà notre modèle de fiche d'investigation et de consentement. Et c'est pour les personnes adultes. Et quand il s'agit des enfants, ce sont les tuteurs qui signent à leur place.
So you have seen the consent that Dr. Kawaya and his team took from patients. Maybe un mot peut-être pour dire que les images sont un peu fortes.
Oui.
Il faut peut-être prévenir. So maybe to tell the audience that we will show now and later on some photos that are quite strong, just for you to know.
Ok. Voilà, donc je nous prie de voir cette image. C'est vrai, c'est quand même difficile, c'est très forte l'image, mais ça nous rappelle la situation, comment elle est alarmante chez nous. C'est vrai qu'ailleurs, la maladie est déclarée terminée, mais chez nous, c'est le contraire, c'est le nombre de cas qui s'ajoutent chaque jour. Déjà, ça, c'est un cas d'un enfant de 13 ans qui a partagé la maladie avec ses frères, dont 2 sont décédés, ils étaient à 4. Et lui, on a pu quand même les récupérer. Et vous verrez par après, il y a son jeune frère qui a fait une très forte, la forme grave de Mpox et que nous n'avons pas pu récupérer malheureusement. Et il y a un jeune, toujours dans leur famille, qui, l'image, donc la vidéo, je ne peux pas mettre ici parce qu'elle est trop choquante et ça peut éveiller vos sensibilités. C'est pourquoi je vous abstiens de cette vidéo. Et déjà, vous verrez que l'habit que le premier a porté, c'est l'habit que le second a porté pour expliquer comment est-ce que la maladie se transmet du fait de la pauvreté dans laquelle vit cette communauté.
Merci beaucoup. I think we need to translate this. So the T-shirt that you saw, the blue T-shirt, was the vehicle for transmission to the other child that you saw later that could not be, that passed away, saved, thank you, that passed away, because the transmission is a skin-to-skin transmission, but here it was transmitted via the T-shirts because they don't have enough money to buy other clothes.
Toutes les tranches d'âge. Donc là, c'est un adulte qui a développé la maladie. Mais je tiens à rappeler qu'avant mon arrivée, on a pu avoir dans les aires de santé où nous allons mener ces études quelques cas de MSM. Mais je crois que la situation est des mal en pu. Voilà, cet enfant que vous voyez fait partie de la famille. Et lui, on a pu le récupérer. Malheureusement, il est resté avec cette opacité cornéenne comme séquelle. Voilà, donc c'est l'autre enfant qui, lui, est décédé. Il a fait la forme grave. On n'a pas pu le réanimer. On n'a pas pu avoir les moyens de le mettre dans une unité de soins intensifs parce que déjà, il n'y a pas assez de moyens pour s'occuper de manière basique des cas. Mais comme lui, il était un cas complexe, donc on l'a perdu. Dommage.
So this was a family of 4 children. 2 passed away, and that little girl of 3 years of age, I think, could not be saved from the disease.
Ok. Donc la situation épidémiologique, je le disais, elle est préoccupante en République démocratique du Congo, avec plus de 24 zones de santé touchées, et avec plus de 208 cas juste pour la semaine 17. Donc la situation est très complexe. Et en conclusion, vu que la situation est critique, la place de la recherche est en tout cas très importante chez nous en République démocratique du Congo et que tout le monde, nous tous, nous puissions nous liguer pour que enfin nous puissions venir en aide à cette population qui, si je me permets les mots, est abandonnée. Merci beaucoup.
Thank you so much, Dr. Kawaya. I think everybody heard the conclusion that we need to find solution with research for this abandoned population. So now we're going to move to Brazil. Dr. Beatriz Grinsztejn works for FIOCRUZ. She's director there, and she is leading one study called Unity together with other partners that we'll hear from. So over to you, Beatriz. I hope everything's working.
Can you hear me?
Very well. We can hear you and we can see you. Perfect.
Thank you so much. So it's my privilege and honor to present in this meeting today. Thank you very much for the opportunity. As Nathalie said, I am a physician and researcher based at the Fundação Oswaldo Cruz. That is the largest research institution in Brazil. That's my country, and it's located in Rio de Janeiro. The main campus is located in Rio de Janeiro. So worldwide, Brazil ranks second in number of confirmed cases of monkeypox. You can put my second slide, please. I can't see my slides. Okay.
Your slides
so
are there.
Yeah. Okay, next one, please. So Brazil ranks second in number of confirmed cases of Mpox and fourth in number of deaths by May 2023. Most Mpox cases in Brazil were concentrated in São Paulo and Rio de Janeiro. I'm based in Rio de Janeiro, where our institution is located. The first case in the country was diagnosed back in June 2022, with the high volume of cases predominantly from July to November, sharply decreasing after that. And currently, we are having around 35 cases oscillating, and 35 cases were confirmed during the last month. Next one, please. By mid-2022, the region of Americas was the epicenter of the new Mpox outbreak, and very few data on the region was available. So we, in a move to address this gap, we compiled data from our cohort of 300 back then in August, 342 suspected and 208 confirmed Mpox cases that we have seen at the Evandro Chagas National Institute of Infectious Diseases in FIOCRUZ from June to August last year. Next one, please. We then continued to follow new patients, and I will present you some detail on cases that were seen continuing after August until December. So we continue to evaluate suspected and confirmed Mpox cases, and we have enrolled by January this year 818 cases, of which 416 were PCR confirmed. Comparing to non-confirmed cases, the confirmed cases were more frequent among individuals aged 30 to 39 years, Black, cisgender men who have sex with men, with low schooling, and very low proportion using HIV pre-exposure prophylaxis. STIs, including HIV, were more frequent among confirmed cases, and confirmed cases were more frequently presented with systemic symptoms, more genital and anal lesions, very painful lesions, and proctitis. I will present you in the next slide some of our cases some of the cases that we have seen. So this is the first case I wanted to present you, was an HIV negative cisgender MSM, aged 28 years old, on using HIV pre-exposure prophylaxis. He was a previously healthy man and presented with fever, headache, and asthenia, followed by pustule penile lesions and inguinal adenopathy. The penile lesions quickly coalesced into ulcers, and he presented balanopostitis and paraphimosis. On day 10, he needed urgent urological referral and was submitted to manual reduction of paraphimosis under the risk of evolving into a neurological obstruction. He later had complete clinical recovery. Next one, please. This is a case of an HIV negative cisgender man who have sex with men, aged 30 years, on also using HIV pre-exposure prophylaxis. He presented with clinical features of proctitis, as you can see, and had inspecific ulcers in an anoscopy procedure. And only after 2 days, he developed a single penile lesion. On day 7, the anal pain got much worse, and at the physical exam, he presented enlargement and coalescence of previous ulcers with blood and discharge, as you can see in the photos. He was treated also for co-infection with gonorrhea and recovered about 1 week later. This is an interesting case because this individual presented internal Mpox ulcers, probably highly infectious, but initially not visible, even before having visible skin lesions. This calls the attention to the potential of Mpox transmission in very early infection phases, even in asymptomatic infections. Next one, please. This case occurred in a cisgender man, 52 years old, living with HIV, virologically suppressed, with CD4 cell count higher than 350. He initially had an odontological problem that required a dental procedure. After that, he was hospitalized due to a dental abscess, with hospital evasion and posterior readmission with sepsis, respiratory failure, and Mpox classical cutaneous lesions. Mpox was confirmed by PCR in the lesion swabs. It was not clear for us until now if the odontological complaints at the beginning were already related to Mpox. But what happened is that his lesions evolved into a necrotizing, as you can see in the pictures, and disseminated presentation. The team suspected of Pyoderma gangrenosum associated and initiated IV immunoglobulin. After that, we were able to get tecovirimat by the Ministry of Health. Our country received only 12 treatments donated by the PAHO, which was initiated at that moment. The lesions were completely resolved 1 month after tecovirimat initiation, and the patient was referred for plastic surgery. And you can see in the right place in the slides that he had a really full recovery after plastic surgery. Next one, please. This slide was from a cisgender man, 32 years old, living with HIV, with very poor adherence to antiretroviral therapy, very low CD4 counts of 24. He attended our service, reporting anal pain and worsening of the mucocutaneous lesions. He presented necrotizing skin lesions, severe anogenital edema, and risk for urological and bowel obstruction. So he also received tecovirimat compassionate use by the Ministry of Health, and he resumed antiretroviral therapy. So he was referred to a surgical support unit and developed bowel obstruction, requiring colostomy, and sepsis occurred due to bacterial translocation. He died due to septic shock, and the medical staff raised the suspicion of immune reconstitution that happened after the ART resumption and the necrotizing presentation of Mpox. Next one, please. This case was a cisgender man, 27 years old, living with HIV, using very irregularly his antiretroviral therapy with very low CD4 cell counts. He presented with progressively worsening Mpox lesions that were already confirmed by PCR, with anogenital mucosal involvement, as you can see in the slides, that coalesced into big ulcers. At hospital admission, he initiated compassionate tecovirimat use through our UNITY study, and treatment for bacterial superinfection was also initiated. And he initially recovered well. And during his hospitalization, antiretroviral therapy was reinitiated, and the patient evolved with worsening again of the lesions after the tecovirimat withdrawal. He presented with recrudescence of the lesions involving palmar and plantar regions, as you can see. Tecovirimat was then reinitiated again by the protocol for a new 14-day cycle, and systemic steroids were also done for potential iris, and with very poor response. We then raised the hypothesis that iris was the cause of the worsening or tecovirimat resistance. After 4 months from the initial symptoms onset, he is now very gradually recovering with virological control of his HIV and immunological recovery of his HIV infection. However, he still presents active Mpox lesions with PCR positive, with a high burden, with CT lower than 20, meaning very high virological burden. Next one is my last case, And in this slide, we compiled several other clinical presentations of Mpox in our population, such as single maculopapular lesions, isolated oral lesions, isolated ocular involvement, and isolated anogenital lesions, just for you to understand the spectrum of the disease in our setting. And next one, I just wanted to thank you very much for your attention, and I'm available for any questions. Thank you.
So, thank you very much, Beatriz, for this very strong illustration of Mpox not being just a small disease, especially in some populations. So, Dr. Grinsztejn will not be able to stay for long, so I would we have planned a Q&A session later on, but if there are questions for her, I think we should give her a chance. So are there questions? Yes, there is one question there, just because she cannot stay for the whole meeting. Yes, you need a mic? Sure.
Hi, sorry about that. Hi, thank you. That was fascinating research. My name is Serena Cruz. I'm with an organization called the G4 Alliance, and we advocate for neglected surgical patients. The question I have is around the patient load and their access chain to the surgery that was needed, especially the patient that needed the plastic surgery and the patient that needed the bowel surgery. From what you've shared, that was part of the treatment chain, right? It was part of how to bring recovery for these individuals. But within your health sphere, within your actual ministry and the research that you all do, how is surgery and anesthesia positioned? And how does that positioning bring them in or out of the case management, is my question. Thank you.
Thank you. Thank you very much for it's a great question. So we fortunately have in Brazil an universal access public health system that is unfortunately very insufficiently funded. But in the cases you saw, we were able to manage the patients, all of them, all who needed any surgical procedure within our universal access public health system. It is not easy, but we were able to manage them in the public health system. In many units, we sometimes struggle a lot to find a way to put them to make them have access, but in these cases that we presented, we were very fortunate, including the guy that had the necrotizing neck disease. That was really, really impressive, the recovery he had, and we were able to refer him to plastic surgery, all within the public health system, and he is very happy with his new neck. Unfortunately, the guy that needed the bowel surgery, he was evolving he had very severe disease, and highly suspicious of immune reconstitution syndrome after reinitiating antiretroviral therapy. So the situation was out of control with bacterial superinfection. I hope I have helped.
Another quick question, because we're, sure. Yeah, please, yeah, I think we should give you a chance. Thank you.
Thank you very much for a great presentation. I'm Joseph Suada from Slovak Republic, and I would like to know, because also topic of the event is global action to cover the needs. Have you had organized diagnostics, and perhaps whether you calculated average time from symptoms until really diagnosis was provided, and whether you see any other opportunity for better collaboration, because you mentioned that only 13 doses of specific treatment you have received from global partners. So how you see it from clinical point of view for the future, perhaps? Thank you.
Thank you. So what I can tell you is that we have access to diagnosis in Brazil through the public health system. It is PCR based. The labs are all that are providing this service are all public laboratories that were trained and certified. Having said that, we don't receive the results immediately. It can take 3 or 4 days. Depending on where you are, it can take up to 7 days. So it's not immediate diagnosis, but it is certified, and all these laboratories that are part of this network of public laboratories in Brazil were certified. And FIOCRUZ, where I'm based, has a certified lab that actually certified the other labs in the country. So the diagnostic platform that we have is good, although not as fast as we would like it to be. And for your second question, we just received this 12 compassionate use treatment for tecovirimat. What happened is that the surge has decreased, and we are not seeing many cases anymore. So this is how we are managing it. We now have a clinical trial that is the Unity trial that Professor Yazdan will present you a bit later on in this meeting. And through this trial, we also have access to compassionate use of tecovirimat, but no tecovirimat through the government whatsoever.
Thank you very much, Beatriz. I think I'd like to ask Dr. Kawaya about the diagnostic access as well, en DRC, en anglais ou en français, as you wish.
Okay, about the diagnostic, we have a platform of to collect les échantillons qu'on collecte au niveau des...
Français, ouais.
Oui, les échantillons que nous collectons dans nos différents sites qui sont dans le pays avec un système d'évacuation des échantillons au niveau du laboratoire à Kinshasa, le laboratoire l'INRB.
Et on a le professeur Muyembe qui est en train d'arriver, qu'on peut saluer,
Oui.
qui vient d'être célébré.
Voilà, je peux continuer?
Bien sûr.
Oui, je disais que le système, il est organisé tel que les différents échantillons que nous collectons dans nos sites de recherche sont soit analysés là-bas en amont, mais il y a des examens un peu plus poussés comme les 5 cassages qu'on est obligé de transférer les échantillons à Kinshasa pour que les analyses soient faites à l'INRB, donc notre laboratoire national.
So you're saying that you can do diagnostic at the Kinshasa level, that you can do, but you have to send the samples to INRB in Kinshasa to do the genomics, I would say, yeah. Right? Okay, yeah. That it is decentralized, but still, I think...
Decentralize everything in INRB about to...
But centralized at INRB. Yeah. Maybe this is another question we can ask a bit later on time to diagnostic for this disease. So I think we now have to close. We're a little bit late. I apologize to the technical team. I thank Beatriz so much for... I think your extremely powerful presentation. As Dr. Kawaya, you will come back on stage later, and I would like to introduce my new Masters of Ceremony, Dr. Ogutu, for the next sessions. Dr. Bernhards Ogutu works at KEMRI. He has a lot of experience in infectious diseases. He's a pediatrician. He knows a lot about clinical research as well. He is also a founding board member of PANTHER. So now over to you. Thank you very much.
Thank you very much, Natalie, and thank you for coming to this session and possibly to share and look at some of the things that we are seeing. And I think this is what we call the endemic pandemics in the south. And I think sometimes we tend to forget that they are there, and I think that's what we really want to share, that even when we think there are no pandemics, there's lots of them that we need to address and possibly need to see how well to do this as we get prepared for the next pandemic. And with that, we're just going to see how we can get this global action to really meet the local needs. I think the world has been used to structured clinical trials where you can plan and do them in settings where you can move patients to structured systems. But the pandemics call for doing research in where the patients are. You don't, if you move them, then you spread the infection. And I think these are some of the things that we have to deal with, the realities of today. If the patients with Mpox are in the village 900 kilometers away, you are not going to move them. The trials have to happen where they are if we are really going to control the flow and possibly the spread. And that's what we are going to possibly listen to a few of our colleagues to share with us some of the things they're doing in the various areas, and possibly I'll start off with Professor Dimié Ogoina, who is in Nigeria and also the leader for one of the Mpox study, the MOSA study that is currently going, and also he's the chair for the strategic committee for the Unity study. Just welcome him to possibly share with us some of the things that things are happening in Nigeria and what they are doing and how they are able to track and run the studies. Welcome.
Thank you very much. Appreciate the organization. Sorry, I'm just waiting for the slides to come up. Okay, you can see my slides now. Sorry, confirm you can see my slides.
Oh, that's what they are going. Okay.
Okay, can you see my slides?
Yes.
Okay, great. So I will talk about how we can global actions to meet local needs in emerging outbreaks, the lessons from the global monkeypox outbreak. So I've categorized monkeypox into the old monkeypox virus that causes the old Mpox and new monkeypox virus that causes the new Mpox.
Possibly you can do away the video and possibly just talk so that the bandwidth is, yeah. The slides, what I need is the slides.
So now we have Yazdan. Sorry, we need the slides. So just also turn off the video.
Yeah, you can just continue showing the slides, but just the video.
Now we need to unmute. Unmute. Yes. Can you tell him to unmute, please? He's muted.
You can unmute yourself.
Okay. Can you hear me?
Yes.
Can you hear me now? Okay, sorry for these little challenges. So I said whether it's old or new monkeypox is caused by double-stranded DNA virus. First described in captive monkeys in 1958 in Denmark. 1970, the first human case was reported in a 9-month-old boy in the Mankunku district in the Democratic Republic of Congo. Subsequently, in the 1970s to 80s, monkeypox resulted to sporadic disease and outbreaks in most parts of Central and West Africa and became later endemic in these regions. What's also remarkable is that in 2003, clade 2 specifically was exported through animal trade to the US, resulting in a cluster of outbreak there. What is peculiar about the old monkeypox virus, which causes the old monkey Mpox, is that it was largely a disease that was restricted to rural settings, a disease that was common amongst children and very young adolescents. and a disease that was largely, predominantly a zoonotic-related disease in terms of transmission. But there's also the new monkeypox virus that causes the new Mpox. Apparently, from phylogenetic study, the new monkeypox virus started in Nigeria in 2016. But we know that in 2017 we had a resurgence of Mpox in Nigeria after a 38-year gap. So we had the first case, who was an 11-year-old boy, and then suddenly we noticed cases across the country. At the end of 2018, about 23 states had reported one or more cases of Mpox. But what was unusual about that Nigerian outbreak was that, as opposed to prior outbreaks of Mpox in Africa, the majority of the cases were among young adults, largely males, and there were a number of cases that had unusual genital lesions, as shown here, unusual genital lesions. We also observed at that time, for the first time, that people that had advanced HIV infection tended to have more severe disease and were also more likely to die. The phylogenetic tree you see here shows that the Nigerian outbreak was caused by the clade 2B strain of the virus. And we have observed that over this last 2017 to 2022, there has been a remarkable microevolution of the new monkeypox virus. And this microevolution has been attributable to persistence and sustainable human-to-human transmission of the virus. And that will likely account to why we had a global outbreak in 2022, where close to 90,000 cases have been reported across the globe. And the majority of these cases, in fact, almost all the cases, apart from a few, are amongst gay, bisexual, and men who have sex with men. Of course, about 50% of the cases are among people living with HIV. And if you look at the type of presentation as has been presented from Brazil, you will notice that most of the lesions were focused around the anogenital area. And that is representative of a largely sexual-related transmission of monkeypox. So this new monkeypox virus and the new Mpox, as opposed to the old monkeypox virus, is a condition that occurs mainly in the urban setting, amongst young adults, and related to sexual contact. If we need to respond to emerging outbreaks, it's important that we take into consideration context. Context is very, very important. And in this case of monkeypox, what is happening in Africa is that we have both the old and the new monkeypox virus, caused by the clade 1 and clade 2. But in the global north, we have the new monkeypox virus. These arrows shows that there's a tendency and a potential for bidirectional spread. So today we have not reported clade 1 in the global north, but nothing stops that from happening if there's continuous transmission of monkeypox in West Africa and Central Africa. So just to be more specific about how the context is different, just giving some differences between Mpox in Africa and the global north. In terms of social demographic, as opposed to the global north, where it's mainly young adult males, urban dwellers, in Africa it's both children and young adults. Both sexes are affected, and rural and urban dwellers have been shown to be affected. Virology, of course, very straightforward, clade 1 and clade 2 in Africa. In terms of transmission, we still have significant, substantial animal transmission, especially in Central Africa. We are not too sure about the level of sexual transmission in most parts of Africa, and that's why the risk factors, the actual risk factors for monkeypox transmission, especially related to the 2022 outbreak in Africa, is not very clear. Regarding clinical features, monkeypox, most of the cases in Africa, even when sexual-related transmissions have been observed, are more generalized. Lesions are more generalized, as opposed to cases from the global north, where they are more localized to the anogenital area. Of course, case fatality is much higher, especially for clade 1 than for clade 2B. And what is also very remarkable is about the public health response to Mpox. In Africa, there are various lacks. Whereas in the global north, we have better funding, more investments, and limited access challenges that I will emphasize in the next slide. So this just to give some of the bottlenecks, context-specific bottlenecks we face in sub-Saharan Africa regarding monkeypox, and it applies to other emerging outbreaks. So we have significant knowledge gaps, limited research capacity, weak public health system. And knowledge gaps could be related, of course, knowledge gap in monkeypox is actually very unfortunate. We have had monkeypox for 50 years and there are so many things we don't know. We don't know the definite ALIMA reservoir. We don't know the definite natural history of monkeypox, the probability of reinfection. We don't know the potential of sexual transmission in Africa. We don't know the efficacy of vaccines yet because we are yet to do the studies. There's also limited research capacity, especially as it relates to Africa. A review of the PubMed publications, for instance, in the last 50 years, you'll be surprised that less than 20% of the publications had African authors as African researchers as first authors. If you look at the 2022 outbreak, for instance, and most of the publications in PubMed, less than 5% of publications are from Africa, and that tells you there's a significant gap in research capacity and publication from Africa. Weak public health system is also part of the challenges we face in Africa, and that's also related to funding and investment. And monkeypox emerged in the global north, and we're having thousands of cases. And if you look at 2022, we have less than 2,000 cases reported, confirmed cases in Africa. But that is largely an undercount because a number of the cases in Africa are actually not detected. And Dr. Kawaya's presentation in DRC is an illustration of that. There's also issues related to inadequate technology, whether it relates to data sharing, diagnostics, rapid antigen tests, serological tests for monkeypox, whether it relates to development of medical countermeasures. There are significant gaps in Africa. Of course, there are challenges with political leadership. John Maxwell says that everything rises and falls according to leadership. And we have challenges of political commitments to do the right thing that relates to addressing our health challenges. And our institutions, our systems have challenges of accountability. So the idea of openness, transparency, and the likes is a big challenge. And that affects public trust. Because in most parts of Africa and in many resource-constrained settings, and even in the developed world, there are issues of public trust in the public health system, either because of repeated failures to meet the needs of and priorities of the population. And there are also issues of apathy to public health challenges. For instance, a typical example is the COVID-19 outbreak. When we had the COVID-19 outbreak, Africans were yearning for vaccines. The vaccines did not come. And they survived, a number of them survived. But when the vaccines came, there was apathy. People became uninterested because apparently they felt they could survive COVID. And that's the same challenge we are facing with monkeypox. Monkeypox is declining in the global north, and most parts of Africa still do not have. In fact, I believe all parts of Africa, maybe for research, still do not have therapeutics and vaccines. Health inequity is a challenge that it's always on the table being discussed, and there are challenges of disparities in the whole value chain of health development, health processes, and health outcomes that we need to tackle collectively. So what are the imperatives? There's a need for call for a global action. Monkeypox has been a neglected disease for many years. 50 years we have had monkeypox, and it's really unfortunate that it's just recently that we are developing vaccines and therapeutics. And we should recognize that because infectious pathogens have no borders, we are like a chain, we are all connected, and we are strong as the weakest link. So it's a time for us to invest. We should not allow history to repeat itself. Monkeypox must not be neglected again. And if we do not work collaboratively and cooperatively and take global action to address this challenge of monkeypox, we should understand that nobody is safe until we are all safe. Thank you very much.
Thank you very much, and it is a pleasure to know that monkeypox is not the same across the globe, and it looks like it is going to behave different in different settings and in different comorbidities that are likely to happen. And I think that's what you have seen. And as much as there's underreporting from some of the regions that we know. So I think the next speaker is going to possibly tell us much about the unity study, and this is Professor Yazdan, who has several hats, but also is the vice president of PANTHER. Yazdan, welcome, and share with us some of the intricacies that you are dealing with in trying to make monkeypox a disease to discuss and to be at the table.
Thanks a lot. Thanks for your nice introduction and thanks for the invitation. I don't know if I can have my slides, if possible. It would be great. Thanks a lot. What I have been asked to talk is about the actually the need for the collaborative rapid multilateral research response during the epidemic, and to talk about the case of monkeypox. Next slide. So you know that, I don't know what is, why we have this title, but anyway, previous outbreak, you should not took that to the title, but anyway, previous outbreaks, epidemics and pandemics have shown, as you have seen for COVID-19, that clinical research response efforts are delayed and fragmented during a pandemic or during an epidemic, failing to enroll a sufficient number of patients. And for example, for COVID-19, most of the early research responses were initiated at only the national and regional level, and few trials were set in low-income countries. Next slide. This slide is just to show the general Mpox context and to see how and whether we had improved in setting up collaborative research or not. So, you know the dates, you know that monkeypox was declared by WHO as a fake, you know the number of cases, you heard from Beatriz, from Dimié, about the outbreak. What I want to emphasize is on what you can see on the bottom of the slide, is that there is, in this context, a real need for cooperation, inclusiveness, capitalizing on the diversity of the expertise for the benefit of all the affected population, and also the fact that maybe the disease is not always the same at all the region, as it was explained to you already. Next slide. So we tried to build actually a new model of clinical trial, which is the UNITY study, and probably, although there are still some negative points, I think we did some progress. So UNITY study that actually Beatriz already stated is a study which primary investigators are Professor Calmi from Geneva and Professor Grinsztejn from Rio de Janeiro in Brazil. It's a phase 3 multi-country randomized controlled trial to assess the efficacy and safety of one of the most promising drugs in this area, which is the tecovirimat. So I think that one of the main positive points here was that very early, based on a trial that was already actually planned but not started before the epidemic by INRB, so the National Institute of Infectious Diseases in Kinshasa, headed by Prof. Muyembe, and NIH, they had already designed a trial. So based on this trial, WHO, with the help of ANRS, actually, and all the researchers tried and succeeded to construct a WHO core protocol. And this was very important. So based on this core protocol that was focusing on tecovirimat in a specific population with the primary objective of evaluating clinical efficacy with a specific primary endpoint, several studies were built, among which the UNITY studies. Next slide. And basically, we tried to have within this study a multi-level governance system at the international level, a global governance where each individual country or region sponsor and implement the clinical trial under the umbrella of a common governance that was coordinated by ANRS, with a global coordination, a global data statistic and data management, a common DSMB, a common safety pharmacovigilance, and working groups to discuss different aspects. And within this global, there was a local governance where the protocol could be adapted, and the study operation implementation could be adapted. Funding was funded by each of the countries. There was the ethical committee submission, the insurance, and the data monitoring. So there was the fact that the countries could be independent, but there was a global coordination. Next slide. And this was within a larger consortium, which was Mpox response, was funded by the European Union, where you had unity, but also a part of the study that was focused on Europe, epoxy, and a part of the study that was in Africa, which is MOSA, and the idea was, again, to use the same core protocol with close collaboration on data repository, data management, representativeness in a global governance, a shared DSMB, as you see here, to try actually to leave to each region or country its independence, but also have this global governance experience. And this is actually now discussed in a paper coming out in Nature Medicine. Of course, everything was not simple. We had, in particular, difficulties to start because of the delay of the authorizations, but we have started. I will show you afterward. And also, we had some funding issues that were not easy. But again, we have this funding from Europe. And what was interesting is that given that the study, the 3 studies were funded, but given that there were no cases in Europe, European Commission is normally accepting that some of the money that was for Europe goes to Africa and to Latin America, which I think it's also very important. Next slide. And I just wanted to say, because I don't know why it has disappeared before the slide, that currently in Unity, we have more than 30 participants enrolled. This is especially in Brazil, where the epidemic is still occurring, and thanks to Beatriz Grinsztejn team efforts, which are huge, and we are now going to also start in Argentina, in Latin America, but there is not only this studies, there are other studies, STOMP, which is in the USA, by ACTHD, Platinum in UK, there's also Platinum Canada. And so I think the fact that there was several studies, that's the way it is, good or bad. But what at least we did at the initiative of the UK researchers is that the fact that the WHO core protocol was used was very important, because now we can merge all the data, and there is the idea of an individual patient-based meta-analysis for reaching the final objective of a quicker and stronger answer on this drug, tecomirimat, efficacy. And it involves all the clinical trials, everyone agrees. So, and you can see that each of the studies have only few patients enrolled because the epidemic went down. But what we can do at least is that we can maybe with this meta-analysis to have quicker answers. So you can see there was still some issues, funding issues, the fact that we started early, we couldn't start early. I think we are still too slow to stop, but at least the fact that I have the same protocol to work together to try to do this meta-analysis, or at least a step forward. So I just wanted to present this as an example. We have still many progresses to do, but we are progressing. Thanks for your attention.
Thank you very much for sharing with us, and I know you're not going to be with us for long, and I think this just explains how some important interventions and possibly networks struggle to get very clear answers for a very major global problem. And I think this is what the Unity study possibly exposes to what is happening despite having gone through a pandemic. Still, we have not learned very well. And there's something burning that you'd want to know from Yazdan. I think we might release him because I think he'll not be with us during the Q&A. Okay, thank you very much. And I think we'll possibly go to our next presenter, Marie Jaspard, who is going to possibly tell us some of the networks and a few things that they are doing and bringing into different platforms to get some work done, and also tell us some of the issues they are facing with in this landscape. Welcome.
Thank you very much. So thank you very much. I don't know if I will have my presentation. I will not be able to present the presentation of Mimi. So please, can I have mine if it's possible? Or we switched? I don't know. No?
Why don't we ask Mimi to start?
Of course. Yeah. Thank you very much. It was.
All right, possibly is to welcome Mimi. Just come. She's one of the strong leaders of Africa, leading one of the best and possibly formidable regulatory authorities on the continent in Ghana, and shepherding quite a number of regulatory authorities as well. And Ghana has always been there, and I think they are the people who do the unique things in the continent. They are the first country to name a public health institute after a local researcher to celebrate. Yeah.
No, it's Mimi.
So we might let her tell us some of the things that possibly, from a regulator's point of view, what happens in this landscape.
Yes. Go ahead. We don't have slides. Just tell them not to show the slides.
Yes. She's not having slides, okay? Welcome.
Okay, so I'm not telling regulator's point of view, sir. Thank you very much. I think I'm probably talking about AVAREF. Yes, okay. So thank you very much. So I'm here to talk about AVAREF, and I chair the steering committee of the African Vaccines Regulatory Forum. So that is what I'm going to talk about. So the AVAREF is a regulatory forum that is made up of national regulatory authorities on the continent, ethics committees. We are supported by the WHO Africa region as a secretariat. We are also supported by NRAs who have referenced, what we call the reference NRAs, who have taken part in maybe the early phase trials that we would be discussing. And we are also supported by partners like Bill and Melinda Gates Foundation, Wellcome Trust, AUDA NEPAD, and maybe USFDA. Now, the good thing about AVAREF is that it allows sponsors to submit applications for protocols to us, to multiple countries, and have those protocols reviewed jointly by countries. And what it does is that it allows us to, for protocols to be optimized so that we are able to review the protocols in a timely manner. And this effect was felt especially during COVID. I mean, we felt this during Ebola, but Ebola did not affect the entire world. But during COVID, for example, most of the COVID medicines COVID vaccines that we all authorized was done by joint review. So within a short time, most of us reviewed all the COVID vaccines for most of us, and in a very timely manner. With the AVAREF processes, all the countries have adopted the same guidelines, have adopted the same format. So if you go onto all the AVAREF members' websites, you find out that we are using the same guidelines for joint review, we are using the same guidelines for clinical review, we are using the same guidelines for GCP. And if you apply for a joint review, you can have it done in a short time. We now have joint reviews for emergencies, we have joint reviews for pandemics, and if you apply to AVAREF, you will get your protocol reviewed in a short time. We also have a system where you can get an approval for a product that you want approved. It also provides better clarity for sponsors that want to use a national process. The good thing about AVAREF is that we know that when you go into a country to submit a protocol, you have to deal with the ethics committee, you have to deal with the regulator. We don't work together in countries. I mean, even in Ghana, where we have semi-good systems, we don't work with our ethics committees. So recently we had a system where we tried to sit together with ethics. It was a bit of a nightmare. But what the AVAREF has allowed us to do is that we are now speaking to each other. So we now have, within all our countries, we now have a challenge where we are trying to draft an MOU between ethics and regulatory, where we're saying that we will have an MOU between us in each of our countries where we will agree to work within a certain timeline using the AVAREF system. So if you apply to AVAREF, then the regulator and the ethics will agree to submit an application and agree to work within a certain timeline, so that there is what you call a parallel submission can be made, and the sponsor can agree, or the sponsor can be assured that within that timeline, once they've submitted an application in a parallel manner, they can get the application reviewed within that time, and we have both signed that MOU. That is a process that has just started, and we have, it started maybe about 3 or 4 months ago. We have committed to that process, and we are hoping that within the next couple or so months, we will all the countries are encouraged to sign it, so that when there's a parallel submission, ethics and NRAs will work together to ensure that when you submit a protocol, it will be done within that time. But at least the goodwill is there. Sustainability is one of the challenges that we have. We can't have partners funding everything that we do. So there's going to be some cost that will come to sponsors of applications. And we hope that you will agree to pay those little sums of money so that we can ensure that that process continues. When that happens, we'll come to you for that amount. But the beauty of the AVAREF process is that it is a learning process every day. So each AVAREF meeting that we go to, the smaller countries or the weaker NRAs have, it is a learning process. We have webinars where countries are developing themselves all the time. So they will not take as long as they do to review an application, and it is a learning process for us. A lot of work has gone into it, but the good thing about it is that the systems are harmonized, the guidelines are harmonized, and we get better at it all the time. Before, it used to take countries sometimes 300 days to review an application. Now we are all down to roughly about, actually some of the smaller ones are doing it even faster. We are down to about 30 days to review an application, and we're getting even closer. So all in all, we're getting there. Once we sign these MOUs, I think we should be there. So in a nutshell, that is what I have to say about AVAREF. Thank you very much.
Right. Thank you very much, and I'm sure there are going to be fairly many questions about AVAREF, and I think we shelve them for the next. And now it's your turn.
Thank you very much. I rather discuss with you about Lassa and AVAREF, so I'm glad to have the good presentation. Thank you very much. So I think we'll change a bit the disease. We have talked about monkeypox. Now we will discuss a bit about Lassa fever. Next slide, please. C'est là. It's me. I'm sorry. I'm really sorry. Sorry. And yeah, okay. I can see something here. Okay, great. Thank you. So sorry for this. Okay, so maybe all of you are not familiar with Lassa fever, but it's a Lassa virus in the family of arenaviruses, and it's responsible of viral hemorrhagic fever. WHO estimates that more than 5,000 cases died per year in West Africa mainly. The reservoir is the small rats who defecate or urinates in the houses of people, mainly in West Africa, and who is responsible of the spread of the disease. And then you have also human-to-human transmission. The most affected country actually is Nigeria, where we can count almost 1,000 patients per year. And I've been working with a French NGO named ALIMA since 2017 on Lassa fever in Nigeria, where we have set up a medical center for Lassa fever. You can see picture in this slide. You can see that we are performing dialysis, that we are treating patients, and also that we worked on the laboratory in order to do diagnostics. We have set up the LASCOP cohort, which is a prospective Lassa virus cohort, and we have identified in a prospective way a mortality of 13%, which was not totally known at that time. We have found out that maybe most of the patients and all of the patients, receive ribavirin for the treatment of Lassa fever, and some patients, 8%, had access to dialysis in this cohort. For the patients who have been having dialysis, half of the patients died in the follow-up of those patients. The prognostic factors were age, over 35, CT value, of course, like as usual, NEWS2, which is a clinical score evaluated at admission of the patient, KDIGO score, which is a way to evaluate kidney injury, and ALT level. Whereas we have been given ribavirin, some questions have been raised on efficacy of ribavirin. Many of our colleagues, researchers from UK and Germany, identify lack in the data available on the ribavirin efficacy. So there is there is an important need for therapeutic options, new ones, such as the ones that are listed here and that I will present to you. So based on all this information we gather with LASCOP study, we set up the Integrate project. When I say we, it's a large consortium, as you can see here. There are all the partners of the consortium in this slide. So 15 partners, North and South institutions. And this consortium have been built on 15 years collaboration. Not all the partners are working together since 15 years, but at least there are collaboration between us and Nigeria, us meaning ALIMA and University of Bordeaux, between our colleague in Germany and Nigeria also, between North Carolina University and colleagues in Liberia. So all these partnerships have been set up in this consortium in order to try to find effective treatment for Lassa fever. This consortium have already organized and finalized the Safari trial, which is a phase 2 study on safety for favipiravir evaluation. Data will come shortly, hopefully. And now we have set up the Integrate study, which is a adaptive platform, a randomized phase 2-3 control, of course, in West Africa to evaluate new drugs or repurposed drugs against Lassa virus. The control arm will be ribavirin because it's a standard treatment. And the first drug we will evaluate will be favipiravir. We plan to include all patients with all ages with Lassa virus confirmed infection. Of course, we have... Thank you. No, you don't see, but there is this nice woman who just raised a paper saying that you have only 2 minutes remaining, so it's a bit strange. Thank you very much. Okay, so this is funded by European Commission and by ANRS, of course. And what is important in this study is that we have a drug prioritization board aiming at evaluate what new drug can be included or not in the study. Within this integrated project, and this is what we are doing in partnership with PANTHER, is that site preparedness program, because we have 2 main sites in the integrated study, which are 2 sites in South Nigeria, Ogo and Irwa sites, which are mostly ready for the trial. And we plan to have more sites included in the trial. And those sites are actually named satellite sites and are listed in the map in this slide. So you can see sites in Guinea, in Liberia, in Benin, and another site in Nigeria. And the aim of this program is to prepare those 6 sites for the inclusion in the next in the integrated study. So what did we do? First, we select 6 sites that are interesting in terms of epidemiology of Lassa fever. We send a questionnaire to all those sites to evaluate their capacity. And then we, not me, but Nathalie here, you can see a photography of Nathalie in this slide, in Liberia with her colleague, Billy Fisher and Beatriz. So my colleagues went to each site to do the evaluation, to discuss with the sites, to see what are the needs in terms of capacity strengthening. We then edit a capacity strengthening plan that needs to be implemented in the coming months and which will be done before the end of this year. The capacity strengthening plan includes training needs in terms of patient care, GCP, GLP, and other needs. Of course, also equipment. You've seen that dialysis is important in Lassa fever, so we plan to set up dialysis in sites that need it. Oxygen concentrator and laboratory device and other items. Of course, as usual, issues with energy and waste and water sanitation. All this is evaluated by the plan, and thanks to this plan and to the implementation of the capacity strengthening, we will be able to raise those satellite sites to study sites at least for integrated study. And those sites will be ready early 2024 if everything goes well. So Lassa fever is here just an example. We have been working on disease for several years, but we think that all we have learned and all that we will learn in the coming years will be helpful for other diseases. I don't know what you think, but for me, I think the next disease will be, the next outbreak and the disease X might be a viral disease, because we have seen in the past year that COVID, monkeypox, Ebola, Marburg, influenza, measles, all those diseases have emerged or re-emerged or cause outbreaks in the world, and all the diseases are viral diseases. So we really think that it's important to move forward on the clinical research on drug dedicated on virus, so antiviral drugs. From the integrated study, we'll be able to gather some information on the antiviral drugs we will be evaluating. So like favipiravir as the first one, but other drugs, and also information on drug association. We really think that, as for other viruses well known, we might need drug association for those diseases. And so this is some questions that we might be able to answer with integrated protocol. We'll gather information on safety, on PK, on PD, and on the use of those drugs on vulnerable populations such as pregnant women and children. And of course, with the site preparedness program, we will be able to build capacity on sites and then to be able to respond to new outbreak in terms of clinical management of patients first and also clinical research. And here you can see some examples. The first one and the only one I will discuss is the Ebola virus disease that I work on for several years also. So you know that there is a treatment based on monoclonal antibody who have been validated in the last outbreak, in one of the last outbreak in DRC. This works very well, and it's a very interesting drug, but its efficacy is a bit low on severe patients. And those drugs are not available to clear the reservoir of the patient. So we think that we need to have drug combination for Ebola virus, and we need to associate antiviral drug. So again, back to antiviral drug, and we think the response is probably with both drugs. So Ebola is just an example, but for the next outbreak, for the disease X, all those steps on antiviral drug knowledge might be useful. So in conclusion, very quick, Lassa fever treatment is under evaluation in the trial I've just described, and we will submit to AVAREF this protocol in the coming weeks. We have been preparing 6 sites in West Africa for medical care on viral hemorrhagic fever and clinical research in collaboration with PANTHER. And we think that antiviral treatment research is really important to take care of the next outbreak. Thank you very much.
Right. Thank you very much. And you can see there's still more work to be done on what we might not see as pandemics, but they are existing and causing more problem. And there's no better person to possibly talk about some of these things. He's been in the trenches for fairly a long time dealing with these viruses, and it's none other than Prof. Muyembe to say a word.
Bon, voilà. Mpox, Ebola, Lassa. Bon, heureusement, dans mon pays, la République démocratique du Congo, Lassa n'existe pas. Pas encore. Bon, voilà. Et c'est surtout donc Ebola et Mpox. Alors, Mpox, je pense, c'est une vieille maladie qui était confondue avec la variole. Et le fait de vacciner contre la variole, on protégeait contre le Mpox. Et lorsque la variole a été éradiquée et on a arrêté la vaccination, et Mpox a apparu. C'est l'héritage que nous laisse l'éradication de la variole. Je pense, parce qu'à l'époque, surtout en Afrique, il y avait 2 formes de variole. Il y avait la variole grave et la variole modérée qu'on appelait alastrim. Et peut-être alastrim, c'était confondu avec le Mpox. Et donc, chez nous, le Mpox vient d'abord, n'est-ce pas, de l'animal, du réservoir, et attaque surtout les enfants. Et les enfants malades vont donc infecter la famille et les ménages. Après, donc, c'est la transmission de personne à personne. Nous n'avons pas vu de cas dans la sphère sexuelle, quoi. Nous n'avons pas vu. Et maintenant, avec ce que nous voyons à l'Afrique de l'Ouest, pour nous, c'est quelque chose donc de nouveau. Et le Mpox a attiré notre attention dès 1980. Bon, dont le premier cas, c'est en 70. En 80, l'OMS a mis en place un système de surveillance active parce qu'on craignait que le Mpox puisse prendre la niche laissée par la variole et donc abîmer tous les bénéfices que nous avons obtenus par le programme mondial de l'éradication de la variole. Mais après, donc, pardon?
Est-ce que je peux essayer de traduire? Je vais oublier après.
Ah, ok. Oh, je croyais qu'à Genève, on parlait français. Ok.
Just 2 minutes, because I think it's so important. So I think you're saying that Mpox is an old disease, which might have been misdiagnosed at a time where you had the 2 different forms of smallpox, but then
for me.
Yes, that's what you're saying, and that it reappeared when smallpox was eradicated, and it's now coming up again because of the interruption of the vaccination against smallpox, that it's an animal transmitted disease, and that it then just continue maybe.
Oui, ok. Donc, nous avons mené des études, les premières études, qui ont montré que le monkeypox n'était pas un danger pour le programme d'éradication de la variole. Mais 10 ans plus tard, nous avons mené également des études qui ont montré que le nombre de cas de monkeypox ne fait qu'augmenter, et c'est même 20 fois plus que ce qu'on voyait au départ. Donc, c'est devenu un problème de santé publique.
So now you have seen that since 10 years that it's increasing. It's been increasing 20 times more, I think you said, than before, and it became a public health problem of concern, at least for the DRC.
Oui. Donc le nombre de cas ne faisait qu'augmenter, et notre grand problème, c'était les diagnostics. Pour les diagnostics, nous devions parfois prendre les échantillons, envoyer ça en Allemagne, ou bien envoyer au CDC à Atlanta.
So the problem was mainly diagnostic. At that time, they had to send sometimes the samples in Germany, and then from Germany to CDC Atlanta.
Mais maintenant, nous maîtrisons complètement les diagnostics de monkeypox jusqu'au séquençage, et nous le faisons localement, d'abord à l'INRB, et maintenant c'est décentralisé dans les provinces.
Yes, and this is what also Dr. Kawaya said, that now you're doing decentralized diagnostic, including now sequencing.
Oui. Et les études actuelles que nous faisons, c'est des études essais cliniques avec des covirmat que nous menons dans 2 sites, au Maniema, à Tunda, et au Sankuru, à Kolé.
So, and now there is a study called PALM 007 that is done in the DRC in 2 sites in Maniema and Sankuru province.
Yeah. Voilà, je crois que tout le monde attend les résultats de ces essais cliniques, parce que le Congo est le pays le plus affecté par le monkeypox, et nous ne manquerons pas de cas pour continuer notre essai clinique. Yes.
So now we're all waiting for the results of the tecovirimat study.
Yeah, because the DRC is the most affected country, so we will not lack cases of monkeypox to continue our study, our clinical trial in the field.
Thank you. I think we should thank you for this update. It's a nice, it's really important to have your views on this. And I think you also have to leave soon. So we have Prof. Muyembe here. As you know, he's just been acknowledged and recognized by Dr. Tedros for all his achievements in the past. So if there are burning questions, I think, I'm sorry again for the organizers, but if there are questions for Prof. Muyembe, please share them with him now. And I'm sorry as well, because it seems that online people cannot see you because you're standing here and you're not sitting there, but that's,
Okay.
But maybe if there are burning questions, please, from the audience. Yeah. Yes, there is. Suri. Okay.
Merci beaucoup. Je vais essayer de m'exprimer en français. D'abord, félicitations pour tous les grands accomplishments, je ne sais pas le mot en français, de toute votre carrière. J'ai une question sur le changement de culture de collaboration internationale dans le domaine de la recherche scientifique. Il y a eu récemment, je pense, beaucoup d'attention sur le concept de la decolonisation, d'avoir plus d'équité entre les chercheurs dans le nord et le sud. Moi, je pense que vous étiez vraiment un grand leader, quelqu'un qui défend qui a défendu les droits des chercheurs dans les pays en développement. Donc, est-ce que vous pensez qu'il y a eu vraiment un changement, que la nature des collaborations internationales dans le domaine scientifique, ils ont devenu plus égal, plus équitable. Oui, voilà, c'est ça la question.
Oui, bon, c'est très délicat. Je comprends.
So, sorry, I'm sorry. Pardon, mais do you want to translate your question in English? No?
Oh.
Because we have English speakers.
My question is very simple. It's have international research collaborations become more equitable over time? Because Professor Muyembe has been he's a star and a leader in this field. He's worked for many decades. He's seen it all. So, have things changed?
And my answer also is very simple, because I think at that time we have no critical mass of researchers. For example, in my institute, I was the only PhD at that time, but now we have 27. So the critical mass is very important to conduct research locally and to have the leadership. Yes, I think for the moment we have no problem with our partners. And we decided in my institute not to send sample abroad, outside the country. We must do everything locally because we have all the equipment you can have here in Geneva or in Louvain. We have the same equipment. So we process all samples locally, and not to export these dangerous samples to Europe or to America. It is too dangerous, and we prefer to do everything locally. Yes, but the partnership are very strong, and c'est un peu gagnant-gagnant, win-win. Yeah, this is very important. Okay.
Yes, there's another question. Maybe, Prof, do you want to say?
Merci beaucoup.
Passer par là, parce qu'il vaut mieux que tu vas. Comme ça, tout le monde va te voir. Ce sera beaucoup mieux.
Oui. Okay. ALIMA.
Voilà.
Oui, ok.
Merci beaucoup. Je voudrais dire ma joie de voir le professeur Muyembe. Je suis professeur Dimié. Je suis enseignant, chercheur, je suis directeur de l'Institut national d'hygiène publique à Abidjan. Je sais qu'à la faveur d'Ebola, on a une équipe de RDC qui est venue nous appuyer pour nous préparer éventuellement à une épidémie. Et vraiment, ça a été une belle expérience à l'époque. Je reviens pour dire que le Congo, la RDC, est un véritable laboratoire, vous l'avez dit pratiquement, pour toutes ces maladies à potentiel épidémique. Et je retiens qu'aujourd'hui, vous avez beaucoup d'expérience. Je pense que ça sert énormément. Et avec le développement du laboratoire, ça a énormément servi pour la réaction prompte. La preuve, les cas d'Ebola qu'on a maintenant, c'est des cas qui sont gérés en si peu de temps. Pour en revenir à, comment on appelle ça, le monkeypox. Le monkeypox, les cas que nous avons, des cas suspects que nous avons eus, c'était des enfants, vous l'avez très bien dit, mais il y avait un rapport avec les rongeurs, parce que c'est les enfants qui sont souvent en contact avec les rongeurs. Est-ce que ça a été la même situation chez vous?
Oui.
Deuxièmement, je voudrais demander, et ça c'est peut-être au docteur que je vais demander, est-ce que ces enfants-là, dans la surveillance, est-ce que vous avez pu établir les contacts avec les autres? Parce que dans le suivi des contacts, c'est vraiment une stratégie importante pour pouvoir arrêter la dissémination de la maladie. Quelle a été la stratégie de suivi des contacts pour qu'on puisse arrêter? Ou bien c'est resté localisé au niveau des familles, parce qu'on sait que souvent dans certains campements, dans certains groupes, quand les gens sont dans la forêt, ils vivent entre eux et ça favorise quand même le fait qu'on peut facilement canaliser la maladie. Est-ce que ça a été la même situation au Congo? Merci. J'en ai fini.
Merci beaucoup. Juste, je n'ai pas entendu de quel pays vous parliez.
Côte d'Ivoire.
Côte d'Ivoire.
Oui,
super.
Côte d'Ivoire.
Okay, because
oui.
the question was from Côte d'Ivoire.
Oui, from Côte d'Ivoire, oui.
Thank Prof. Muyembe for the training he has provided with the NRB for the diagnostic of many diseases. And now coming back, je fais court, hein? Coming back to Mpox to ask how you manage contacts and follow-up of the environment of the other surveillance of the other contacts.
Merci beaucoup.
OK. Oui, vraiment, l'INRB, donc la RDC, comme vous le savez, la RDC, c'est un continent, c'est un pays qui n'est pas seulement riche en matière de minerais stratégiques, mais également riche en infections. Hein, parce que le pays est grand, beaucoup de forêts, beaucoup d'eau, etc., etc. Alors, nous avons développé comme ça, donc, vraiment une expertise pendant 40 ans en ce qui concerne Ebola et également une vingtaine d'années en ce qui concerne le monkeypox. Et nous partageons cette expérience avec nos pays, nos voisins, les pays de la sous-région. Et vous parlez de la formation. J'étais venu au Grand Bassam pour justement transmettre donc le message à nos collègues de la Côte d'Ivoire. Et maintenant, l'INRB est reconnu comme un centre de séquençage et nous formons également des chercheurs et des techniciens en matière de séquençage de monkeypox et d'Ebola. Cela se fait donc maintenant d'une façon vraiment régulière, financée par la JICA, coopération japonaise, et le Africa CDC et l'OMS. Voilà. Alors, en ce qui concerne le suivi des contacts...
Il faut que je traduise ça parce que je vais tout oublier. You said that you have a lot of resources, including a lot of infections, and you've been doing some genomics, sequencing, and a lot of research and on sequencing, and funded by JICA, you mentioned,
yes.
And
Africa CDC.
And Africa CDC.
And WHO.
And WHO. And now you're going to speak about contacts tracing.
About contact. So I think my colleague will speak.
Merci beaucoup, professeur. En ce qui concerne la gestion des cas, surtout pour les enfants dans les milieux ruraux, comme a dit le professeur, notre pays, c'est un pays continent avec beaucoup de défis, surtout en termes de gestion des cas. Alors, pour faire simple, les principes voudraient que les cas soient isolés. Et surtout quand c'est dans un milieu hospitalier, les malades sont isolés. Mais au niveau, à domicile, les malades également, on préconise l'isolement du malade et on essaye d'expliquer à la communauté, donc un travail psychosocial est fait pour qu'on soit à mesure de couper la chaîne de transmission en évitant de mélanger le malade avec déjà les enfants et aussi avec les personnes adultes. Je crois dans ma présentation, j'ai fait une illustration pour expliquer cette persistance des cas peut-être chez nous, c'est dit à la promiscuité. Donc les problèmes de promiscuité liés à ces manques de respect strict de l'isolement des malades restent et demeurent un défi pour nous. Merci.
Thank you very much. Before we move to the next session, just I will translate. So it's a lot about isolating patients in special wards because it's human-to-human transmission. So the best thing is to prevent transmission by providing isolation and isolating patients. We can come back to this discussion after we have heard from our next speaker, who has been very patient online. And I will ask Dr. Ogutu to take over on this with no translation needed anymore.
Right, thank you very much. And as all of us must be aware that some of these things cannot be done without risks that some people take, and this basically the risk that some people take to fund some of these activities. And with this, then I'll introduce our next speaker just to help us understand some of the thoughts they have and this is Veronika Von Messling from the German Federal Ministry of Education and Research, who has been funding some of the Lassa activities in West Africa and also provided the seed funding for the setup of PANTHER, to possibly come and give us what they see and why they're interested in this landscape.
It's my great pleasure to be at the meeting today, even though only virtually, and to discuss a bit the perspective that funders, especially sovereign funders, have when we look at this developing and fast-moving landscape. So the funding for PANTHER is a great example for what we think is no-regret funding. As its first funder, we supported the idea to establish a sound basis for preparedness in inter-crisis periods. And I guess a lot of the discussions that we heard earlier today were addressing exactly this point. And that can happen either by capacity development, but also by sustainment of research staff and infrastructures. No-regret funding also means to keep the use of funds flexible and allow the possibility to adapt the research plan dynamically in times of crisis. So in the next few minutes, I would like to highlight what has already worked well for us as a governmental funder in terms of pandemic preparedness and response, and why it has worked from our perspective. So long-term funding initiatives that go through our ministry, such as the European Developing Countries Clinical Trial Partnerships, many of you know very well, EDCTP, or the Product Development Partnerships, the PDPs, and also the Research Networks for Health Innovation in Sub-Saharan Africa, called VISA, have been proven to be hugely useful. Although not initially planned for, all these initiatives in their own way have been prepared to conduct research during public health emergencies. And because of this unique position, they had placed themselves before the pandemic. They were able to contribute, I think, way above their original size or mandate. So I'd like to briefly look at the African American Initiative RISA in more detail to give you a concrete example to the elements that we think have contributed to the success. So from the conception on, the priorities have been aligned with local priorities. And compared to many other programs, we implemented a rather unique feature. All networks run under African leadership. So we have a very high level of buy-in by the partners. Furthermore, transferring research and development results into the local health systems and building research capacity were key aspects in the initiative. So that were criteria that were used to select during the funding selection process. When setting up the project in 2016, we really didn't think of a pandemic, not at the least a pandemic like COVID at all. When it then hit in 2020, the 5 networks were at an advanced point of their research already. They had established these capacities not only for doing research, but also for research administration. And that allowed us to quickly react with top-up funding for COVID-related activities. It's just like that, this ability to mobilize top-up funding for already established research structures is another example of no-regret funding from our perspective. We had similar no-regret experiences with EDCTP and product development partnerships. 2 consortia funded with EDCTP on epidemic preparedness were able to focus on COVID-19 as soon as the pandemic hit. And some PDPs were able to set up additional COVID-19 programs quickly based on their expertise and the existing infrastructure. We believe that long-term capacity strengthening for a robust research environment and a resilient public health system, as well as collaboration and cooperation at eye level, particularly in low and middle income countries, are central elements for a global pandemic preparedness and response. Continuous investment in national and international initiatives, even before a pandemic, underline the importance of acting not only in times of crisis, but also in between. An important question for us as funders is, how can a swift and efficient funding be ensured when a crisis actually occurs? And again, cooperation and collaboration are the key. For research funders like us, the Global Research Collaboration for Infectious Disease Preparedness, and you know this probably by its abbreviation GLOPID-R, has been playing an important role in promoting the dialogue across funders on research priorities and upcoming calls for emerging infections. As part of its post-crisis work, funders and clinical networks elaborated a set of recommendations for clinical trial coordination. The 3 goals are to support epidemic-ready clinical trial networks and platforms, to facilitate an agile and effective response, and to promote an equitable research environment. PANTHER is reflecting many of the principles worked out by this group, and this is why we are excited to support this initiative. Being prepared and acting in a coordinated way is essential. At the same time, we must be careful that research does not suffer from overregulation of processes. So sufficient flexibility is equally essential to respond efficiently to different health, political, and socio-economic contexts. So at the end, allow me to give us all some food for thought and further discussion. Although BMBF is already investing in long-term initiatives, they are still program-based, and they will remain program-based, which means they have a certain lifetime. Ultimately, our success is measured by impact. That this impact should not rely on the program-based funding. Ultimately, investments in research, the translation into the healthcare systems, and the uptake by the communities need to be driven locally. Thus, impact has to be generated by the people involved. We need to raise the question how our funding will be sustainable once certain programs end. Are the systems and processes on site prepared to take over responsibilities and standalone ownership? What does it need to be sustainable? Probably no one has an answer, neither today nor in any near time in the future, but there should be a discussion about this point as we go along with these programs. If our efforts yield sustainable results, I would rank that as the best return on investment, and as such, a funding with no regret. So thank you very much, and I'm looking forward to an exciting discussion.
Thank you very much, and it is a pleasure to see how to de-risk research in difficult circumstances, as Veronika has possibly espoused during this brief presentation, and I think does see what it happens and the flexibility that is needed. And I think this is where the issue of regulation and flexibility and achieving the aims of what you need to do during a pandemic becomes quite critical. And that's what we possibly want to see going on. How do we bridge the gap and make sure that we stay in line, but also remain nimble and flexible as we work around this landscape? And that's the problem PANTHER has to deal with, and ensure that there's sustainability and adaptation to the findings into the health systems of the various countries where we'll be doing our work. And I think that's why we have to be on the steering, not somebody else, at the country level, to make sure that what we gain gets translated into health system functions that will provide that health that we need for the population. With that, I think we now are open to discussions, and I know there might have been some burning questions that possibly people want to put across, and it's your time now. Guys online are not sending any more questions, so if anybody needs some clarification made, and possibly see we still have the speakers with us.
Hello, I'm Han Zhi. I'm a visiting scholar in Geneva Graduate Institute. So my question is, I feel today's discussion is fantastic, but I'm also thinking about, because I also attend in other side events, and there are a lot of discussion that global health now is too disease-focused, but it's many experts talking about global health must be more systematic, focused, driven, and but my own thinking is, my feeling is this too is so important, right? So both are important. But my question is how, just like the last professor mentioned about how to make these two kind of approach, they can work together. So how to make this kind of disease focused global efforts can work just together with the different governments that they have on their agenda, that how to make your efforts better converged with different countries' agenda. So this is just some feeling and some comments. Thank you.
Well, maybe I can start answering. There is from a research funding perspective, it is exactly what you say. It is important that it all fits together, and you achieve that when we think about funding calls by planning the calls in a way that the consortia that form are well integrated in the plans of the local and regional and national plans for health research development. Does this always succeed? No. But it clearly seems that this is a good way in the right direction. And I think this is also, we have to have an expectation management. So not everything will work the first time around, like anywhere else. And so we have to go step by step and learn from the successes and the failures, and to move forward in this endeavor, because it is a huge challenge. Thank you.
And maybe I can add some words. I think it's a full-time job to make sure that we all work together. I mean, it's my full-time job. It's a daily challenge, but when it's a success, it's really nice to work in this context. And I would say that it's based on trust between all organizations, between the government. We need to involve the government. We need to involve the regulatory agency. We need to involve the researcher. We need to involve the community, the patients. And if we succeed to put everyone on the same table, it's work. If we do not, you just don't continue your project. So it's a challenge, but it works.
And then maybe if I can add, before Ebola, pre-submissions never happened in Africa. I mean, we didn't have anything like a pre-submission meeting. You submitted your application when you're done with it. But since Ebola, now you can actually come and speak to the regulator about what you want to do. In AVAREF, you have the sponsor and the regulator and the ethics sitting at the table and talking about what they want to do. So things have actually moved. Pandemics have taught us, or emergencies have taught us to work in a different way towards ensuring that we do what is best for the patient. So systems have changed, all looking at the patient at the end and making sure that the patient gets the best out of what we want to do. So I think we are all changing. Thank you.
Yes, sorry.
Very much. I forgot to introduce myself earlier. My name is Suri Moon. I'm co-director of the Global Health Center here at the Graduate Institute. And I want to congratulate everyone and PANTHER for the excellent presentations. I think in many ways we heard a very optimistic and encouraging set of presentations that show how much important research and development is happening in many different parts of the world, how much researchers are collaborating with each other in a way that we did not necessarily see in COVID-19. Very encouraging, and the efforts to build long-term infrastructure and capacity and funding, I think, is also very, very encouraging. However, We also heard about, I think, if I understood correctly, 12 vials of tecovirimat in Brazil. And of course, we heard a number of presentations about Mpox. And I think many people are aware that access to the vaccine supply that was available globally, the smallpox vaccine supply was highly inequitable, just as it was for COVID-19. And so my question for, primarily for the government people and the government funders, which is of course Dr. Von Messling, but also Dr. Ogutu in a way. As we have more government funding of R&D from Germany, but also across sub-Saharan Africa, in Brazil and other places, is it useful for governments to actually tie more conditions to their research funding so that situations like we see today with a vaccine for Mpox or in the future don't keep repeating themselves? And is it, in your view, feasible or beneficial for multiple governments to try to do that together? And I think, as you're both very aware, this is something that is being actively debated in the pandemic treaty negotiations. Not universally agreed upon yet, certainly, but I'm struck by all of the progress made by the research community, and yet we're still facing some of the same challenges with inequity that we've been seeing throughout the COVID-19 pandemic. Thank you.
Yeah, so maybe I can give you a brief answer to this complex question. It is to develop a vaccine or a drug or any type of medical countermeasure is very difficult and usually not successful. So one says that out of 100 candidates, one may make it and 99 fail. There is a huge worry that if you tie any restrictions to this very fragile process, you will have nothing at the end. So the question is whether burdening the research and development process at the early stages with rules and regulations that would only apply if anything is successful is a smart way to ensure equitable access. And I think, as you say, there's a lot of discussion about this. Our experience as a funder in the global north is that there's a lot of research funding that is needed to have a success. And the success happens if there is as little restrictions as possible put on the researchers. And so we would be very hesitant to put any type of obligation at the early stage, which doesn't mean that there doesn't have to be agreements and understandings and rules on how products, once they are developed, can be accessed. But the two things can be separated, and one easy way to look at it is first you have to have it, then you can start distributing it. And once we end up with not having it, then nobody wins. So that has to be balanced out with the question on how and where does one put the regulations in place to ensure this access that I think everybody wants to have. So thank you.
Thank you very much. Unless there's something burning, I know we are running out of time.
Oh, could I just quickly have the last question, if I may? Thank you. I've really enjoyed today's presentation, and I echo Siri's comments. It's really encouraging to hear and optimistic. I knew about PANTHER, but I didn't know about their work, so it's been a really interesting session today, so thank you to all the speakers. I was interested, Veronika, I loved the whole no regret funding. It was something that I'm not really familiar with, and the way you described it and the premise behind it being led by, it's African-led, but you talked about an infinite, because funding, obviously, you can't support these programs infinitely, and there has to be a sustainability mechanism where you say, right, now we stop and we let you take over. Could you tell us about the experience of that transition from when your funding has stopped to ownership, and countries have taken aboard to maintain the infrastructure perhaps that you've committed to over in the time that you've supported the programme, and the continuity after you've stopped your funding in those programmes?
The short answer is most of these programs are still in a stage where they are receiving funding from our side. But part of the design of the programs is that from the beginning onward, this sustainability is being essentially included by design. How well this will work, let's talk again maybe in 5 years and see where we are at then. But so far, to include it from the beginning and to have people think about it and include strategies for that from the beginning has already changed the way these programs are running and the perspective the participants have on the program.
Okay, thank you very much, and I really want to thank my speakers that were able to share with us the ideas they had, and also the members that presented themselves to possibly help us listen and discuss some of the issues. And with that, PANTHER is one of the first initiatives that is going to work across EMRO and AFRO, the bleaching in Africa for the first time. So with that, I'm going to invite the representative of EMRO, Director, to possibly give us closing remarks to this beautiful day that we have had together this afternoon. Welcome.
Thank you. Thank you so much. The Honorable President of PANTHER, the CEO, most esteemed panelists, distinguished ladies and gentlemen, I am honored, privileged, and delighted to be here today, joining you for this wonderful discussion in this great place, Geneva, the Institute, academic institution. I think the question in front of us today is how to prevent the next pandemic. And there had been lots said about that. I'm glad that PANTHER has set up this platform for people, especially researchers, to come forward to present their great work done on the ground. I think people who are sitting in capitals doesn't understand the real ground's realities. But today we were exposed and witnessed to the real situation they are facing. And we need to really come together to work hard to support these great researchers who are doing real great work on the ground. Now, today when we are discussing, the Director General WHO, Dr. Tedros, has declared that COVID-19 pandemic and Mpox is no more a public health emergency of international concern, but still cases are being reported. And what is more important during the discussions in the World Health Assembly, which is taking place now, is how to prevent the next pandemic. And what is more important is how much we need to invest on preparedness. So that is the question which came up, prevention of next pandemic, and focus more on preparedness. I think we need to really focus on surveillance of diseases. Maybe it is integrated disease surveillance or vertical, whatever you have at the country's level. We need to make it, scale it up, strengthen, and robust. Then, of course, surveillance at the point of entries. And more importantly, the question came up about the lab surveillance. We need to have a strong lab system. We need to have connectivity. And then, of course, we need to have the facilities. So today, I am here representing the Regional Director, Eastern Mediterranean region. So let me present to you his statement on closing remarks. I quote, "I would first wish to refer to the WHO Eastern Mediterranean region Vision 2023, which has the strategic objective of addressing the health emergencies, in addition to expanding universal health coverage, promoting healthier populations, and making WHO transformative changes. In fact, WHO also has its own health emergencies program, which works with countries and partners to prepare for, prevent, respond to, and recover from all hazards that create health emergencies, including disasters, natural or human-made, disease outbreaks, and conflicts. I also wish to refer to the World Health Assembly Resolution 75.8 in 2022 and EB 152/13 on 2023 discussion, following which WHO held consultations for member states and for non-state actors like these foundations to receive inputs and comments pursuant to the resolution and what improvements are needed in the global clinical trials ecosystem in normal times as well as during public health emergencies of international concern. That is where our focus is much. The outcome of these consultations supported the role of WHO in convening and thus generating research priorities at the global level. WHO's R&D blueprint has published several documents that support generation of high-quality evidence related to epidemic and potentially pandemic pathogens and diseases. During the COVID-19 pandemic, the Eastern Mediterranean region had participated in global clinical trials, especially countries of Bahrain, Egypt, Jordan, Iran, Oman, Kuwait, Pakistan, Lebanon, Saudi Arabia, and Tunisia. Such participation and commitment helped in developing necessary technical experience and expertise in conducting such trials among different cadres of healthcare professionals within such countries. Moreover, some member states have developed governance mechanisms for holding such trials, not only under emergencies, but also under normal times as well. In addition, the EMRO region has at least 2 primary clinical trial registries, which are linked with WHO's International Clinical Trial Registry Platform, ICTRP, while another 2 are currently in the works to be included under ICTRP umbrella. In addition, the EMRO Region Advisory Committee for Health Research in its meeting convened during May 2022 has recommended further technical capacity building for the conduct of large clinical trials and multi-country studies in the region, as capacity for such studies is very limited in several countries of the region, and as such, the WHO Resolution 75.8 responds to the needs of the countries. Ladies and gentlemen, WHO EMRO would like to congratulate PANTHER for its establishment as a clinical research platform for preparedness and pandemic response, which is in line with WHO's vision on addressing health emergencies. We look forward to collaborate with PANTHER, especially in EMRO countries located in North Africa, in collaboration with research hubs located in different African countries. Thank you. Thank you so much.
Thank you very much, and for the warm words that we've received from you and from EMRO, and we look forward to working together. And with that, I just say thank you very much for being here with us. PANTHER is quietly roaring, coming your way, sniffing for the virus, and we want to make sure you don't meet the virus. The PANTHER should meet it first. Thank you very much, and have a great afternoon.